Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Hello, everyone. This is the Mad in America podcast, and my name is Brooke Seam. I am the author of the award-winning memoir, May Cause Side Effects. Today, I have Dr. Ellen Vora, a board-certified psychiatrist, acupuncturist, and yoga teacher. She's the author of Anatomy of Anxiety and takes a functional medicine approach to mental health. She considers the whole person and addresses imbalance at the root. Dr. Vora received her BA from Yale University and her MD from Columbia University. Ellen, welcome to the show.
Hi, Brooke. Thanks for having me.
Hi, it's so good to see you. You know, we just had about 2 minutes before we started recording where you asked me how I was doing. And I said that, you know, on paper, everything's great, but I'm struggling with like this existential thing of being 38, single, childless, somehow aware of my own impending death at some point in the future and purpose, which is something you mentioned very early on in your book, The Anatomy of Anxiety, about how there's this idea of true anxiety and false anxiety, and that our true anxiety really kind of is asking us to face these existential questions. So I'm going to take just a second and have a little bit of a 5-minute therapy session. Could you just riff on this concept and talk about how that really falls into your work around anxiety?
Yeah. I mean, it exists so naturally in juxtaposition to false anxiety, which we'll get into and unpack and talk about, where it's like, we think there's some heavy duty mental health thing going on when in fact we're just inflamed or chronically sleep deprived or our blood sugar is swinging and so on and so forth. Whereas true anxiety, which I call purposeful anxiety, it's not what's wrong with us. In many ways, it's what's right with us when we are able to viscerally connect to what's wrong in the world, whether that pertains to our personal lives, our communities, the world at large. This is not an anxiety to pathologize. It's not one to suppress, not that we really could. It's not something we get to gluten-free or decaf coffee our way out of. This is our inner compass, and it's nudging us and it's asking us to slow down and pay attention. And I think when it comes to the existential questions, like this massive vulnerability of going through life in a human body where we will one day die, where we will lose the people that we love, where there's suffering, we're not wrong to have true anxiety. Let's be true with ourselves about the fact that there's a lot to grapple with here. But I think that there are tools to be with that. There are strategies for reframing, for moving with that with grace. And I hint at that in The Anatomy of Anxiety. My second book, Season of the Witch, is really where I'm like trying to go push that to 11 and really be with how do we meet and face death in a different way? How do we make meaning in our lives? How do we make sure that we're fulfilled? How do we make peace with when things don't go our way or feel where everything feels unsettled? But I think that what I don't encourage is the coddling that we do around it, where usually it's just something we say to somebody in order to make ourselves feel better. It's like, no, but you're fine, or it'll work out, or rejection is protection. Or, you know, it's like it's all so well-meaning. I wouldn't go as far as to say it's toxic positivity, but I think that we don't want to coddle our way through true anxiety. We want to be with it. And not to say it's all going to go away, and not to say we're stuck and we're doomed, but there's something here to pay attention to and something here to feel.
How do you know the difference between true anxiety and false anxiety?
My algorithm when I work with patients on this is you start with false anxiety because initially we don't know. And I think we're really bad at discerning. And false anxiety is the low-hanging fruit. It's the quick wins, but it's also the kind of sine qua non, or it's in the way. If we're experiencing a lot of false anxiety, then our moods are this pinball game. We're bouncing all around. And it's very difficult to hear the real clarion call of our true anxiety, because we'll mistake a lot of things for true anxiety when in fact it's our blood sugar. And so I first address false anxiety and make sure we've cleaned up the physiologic root causes of anxiety first, so that someone has clarity. We're not wading through muddy water anymore. And then you get still and you slow down. And in that spaciousness, you have a dialogue with some inner part of you that can tell you, here's what's the true anxiety at the heart of it all.
What is the checklist, the algorithm that you go through for false anxiety?
Yeah. So just to define false anxiety, it's such a triggering term. And so, now I don't know how many years into this book being out in the world, like I knew what was coming for me with that term, because we never need more stigma and invalidation when it comes to our mental health. There's plenty of that in the world as it is. I truly don't mean this term in a invalidating or dismissive way whatsoever. False anxiety occurs when something has tripped our body into a stress response. And then we subjectively experience that stress response as anxiety. It can even be panic. But if we look under the hood and understand what's actually triggering that stress response, even though we're taught that our mental health issues are a genetic chemical imbalance, that it's a fixed trait, that it's a destiny, that it's psychological, like sometimes it is truly just a blood sugar crash. And that generates a stress response, and we experience that stress response as anxiety, but it doesn't have some heavy-duty psychological truth underneath it. It's unnecessary. It's not a deeper truth of us. It's just blood sugar. And so we want to identify these root causes of unnecessary stress responses and address them. That checklist contains everything from blood sugar to chronic sleep deprivation, which itself is an umbrella for, is that due to lifestyle choices, or is it due to blue light, or is it due to mouth breathing or sleep apnea, and so on and so forth. Our hormones, our gut health, micronutrient deficiencies, the degree to which we have inflammatory molecules coursing through our bloodstream. There's an enormous topic of food, the way our foods are engineered to be hyperpalatable, they're nutritionally depleted, they're inflammatory. This is creating a physiologic mess inside of us. And then there are some more straightforward aspects of false anxiety, where we're dehydrated or mineral depleted. So the list is long, and there's a lot to kind of like when I work with patients, there's layers to how we're addressing the false anxiety in their body, but it's usually something to do with diet and lifestyle.
What's so frustrating and also fascinating about this in a way is that everybody wants to blame everything on genetics right now, in part because we have so many new tools to do genetic testing and actually see, like, where are the slight differences in you versus me, and how does that change how we live in the world? It's fascinating on that level. On the other hand, you say very early on in your book on page 10, these rates, and you're referring to mental health and mental illness rates, would not have risen so precipitously if these disorders had a predominantly genetic basis. Our genes cannot adapt so quickly as to account for our recent catapult into anxiety. And again, we all know this. We learn about, basic evolution and how long it took for humans to become humans. And yet somehow in the past, let's say 5 to 10 years, our genes have changed so dramatically that now whatever statistic you want to hit on, like 1 in 2, 1 in 3, 1 in 4, 1 in 5, 1 in 6, depending on which study you're looking at, is like the rates of mental illness. And it's just like, this makes no sense from a genetic evolutionary standpoint.
Beautifully said. And we're going to talk about epigenetics. But I think, first of all, let's recognize this has been an improvement upon the old model of understanding mental health. Like, we used to see it as a moral infirmity. We used to shame people for it. So the disease model and the genetic basis came as a breath of fresh air. It was an attempt on some level to destigmatize and to be like, hey, wait a second, let's study this. Let's give credit. Let's legitimize the field of psychiatry and make this a legitimate science. So lovely spirit behind it. What happened is that we took on societally, we really fully were indoctrinated with this genetic model of mental health, where we see mental health issues as a genetic chemical imbalance. And the pharmaceutical industry, this is Mad America, so we can be real
we
here.
We can talk about this.
Really jumped on that as like a pretty good marketing story as well. Because if it's a genetic chemical imbalance, let's address that imbalance with a pill. One of the problems with the genetic story is that it's a fixed mindset approach to mental health. It's basically saying your mental health issues are something about you. You're stuck. It's something essential to who you are. It'll always be so, but no worries, because there's a pill for that. And if you are one of the minority of people for whom are helped by the current offerings of the conventional psychiatric field, that limited menu of basically meds and psychotherapy, if those are the paths up the mountain of healing that work for you, hallelujah, great. I am now, 11 or so years into practice, and I have observed that the majority of people are not adequately supported in that way, and sometimes it causes harm. When we say that mental health is a genetic chemical destiny, if it works for you, that creates hope and empowerment. But if it doesn't work for you, that actually creates despair, because you think, okay, I have this genetic chemical thing about me, but it's treated with a pill. So you try one pill, doesn't work. You try a different one, different dose, add an augmented strategy, and then you're still not better. And you think, oh, it works for everybody else, but I am beyond repair. And that's where I want to cry from the rooftops and say, no. Do not despair. Do not lose hope. We gave you a very limited menu of strategies, and it turns out there's more paths up that healing mountain. And if meds or psychotherapy weren't the paths that got you there, maybe they turned into dead ends. Maybe you were even going down the mountain a bit. Let's try one of these other paths. And so it's a growth mindset approach to mental health instead. It's one that doesn't say, you're stuck, this is your destiny, it's something about you. It says, hey, mental health issues are a manifestation of some degree of imbalance. Let's identify the root cause of that imbalance, whether it's physical or psychospiritual or unresolved trauma. And I think that it's so important to use that functional medicine understanding of genetics, where we say genes loads the gun. Sure, because you don't want to gaslight people. They're like, look, my mom is anxious, my sister's anxious, my maternal aunt is anxious, I'm anxious. Like, it's genetic. Sure, there's a genetic predisposition, but genes load the gun, and it's the environment that pulls the trigger. And genes run in families, but so do environmental factors. And I think that I say this to empower people and give them hope that there is something we can do about it and you're not stuck. Epigenetics is, of course, an important part of this conversation because we're so plastic. We have so much control over how our genetic predispositions manifest. And again, that's empowering. Caveat, or like asterisk on that, it's empowering except when it isn't. And I think that's a big part of why we're so drawn to the genetic basis for mental health issues, is that my goal is always for people to feel hopeful and empowered. But sometimes people feel it as shaming, blaming, judging, and just overwhelming, that they think, wait, I thought that this was just genetic and inevitable and there was nothing I could do about it. And it sucked because I felt stuck being depressed or anxious, but it was kind of comfortable because there was no personal responsibility to do anything about this other than maybe take a pill. And so when we come in and say your diet and lifestyle matters, whether or not you're addressing your trauma matters, we're now handing people a task list and saying, there are things you can do about it, but there are things you must do about it. And we can feel overwhelmed. We can feel judged and blamed for not already doing it. We can feel foolish for not having already done it. I think this is part of what's so rich about that meme of I'm got to take my stupid walk for my stupid mental health. Like, there's so much packed into that. But part of it is that we hate the idea that, was it as simple as just taking a walk and I could feel better? Like, I feel like a fool for not just knowing that earlier. And it feels so dismissive of what feels like a heavy duty mental health issue.
I think at least I have a sample bias just given the wonderful folks I surround myself with and my general obsession with the world of like biohacking and wellness. But the thing that I have realized more than anything in my own personal journey, getting off antidepressants, fixing my body post antidepressants, and then my work, because my day job, I work as a chef to pro athlete. So I'm spending a lot of time with food and, how does food really affect this and the whole environment? And it's so frustrating to me that at the end of the day, it really is so simple. It is addition by subtraction, not layering on supplements and drugs and, the latest protein infused cereal. That is not the way. It is making it simple. And it's so frustrating because it's like, it is so much easier to teach a simple concept than a complicated one. And yet we are just told from the get-go how complicated our bodies are and how complicated mental health is.
There's so much here. I mean, I think that, of course, when we're overwhelmed with everything we have to do, because the stuff that actually moves the needle is simple, but it's hard to do. And our landscape, our world doesn't make it easy, right? So like, we need to get nourishing sleep. We need some sunshine. We need some movement. We need community. We need nourishing foods, like clean water, clean air. It shouldn't be hard. It's kind of just like what was free and existed in a time that I don't envy someone like living on the proverbial savanna of evolution, but these things used to come for free. And now you have to very proactively design your life in a very intentional way to reclaim this. And so there's not really a shortcut. But when we're overwhelmed, we really desperately want a shortcut or a hack. And we believe that maybe if you find the right supplement from the upperest echelons of the bro wellness movement, maybe then you can hack your way through all this drudgery of actually having to lift heavy things and go to sleep early. The wellness industry is weird, right? Like the spirit of it was always, hey, we're going to our doctors, we're being gaslit, we're being bullied, we're being dismissed. They're not taking our problems seriously. I took matters into my own hand. I went on the internet. I saw holistic practitioners. I realized that what I feed myself has an outsized impact on my health. That's the spirit of how it started. And we are now at a point where in certain ways we've lost the plot. And we went from empowering to overwhelming. It's taken on a very consumerist quality. And now, when we start to fear food or feel like our bodies are fragile or decline social invitations because we want to stay home and eat in a particular way, all of this is starting to be counter-therapeutic, where it's not net beneficial for our health. And it's an outcropping of the wellness industry. We also overwhelm ourselves with cluttering our lives and draining our bank accounts and just feeling like, I have to do 20 minutes of infrared sauna and gua sha and meditate and start with this smoothie ritual. And it just ends up meaning that it becomes a part-time job. And so I think that what we want to do instead is figure out what are the non-negotiable fundamentals that move the needle for us, build them in a set it and forget it way wherever possible. Like you just stock these things on your kitchen counter, you set up the shower filter, you do whatever you can that's set it and forget it, not prohibitively expensive, and doesn't make you feel like a patient and doesn't put you in a state of fear. And whatever those practices are that you can easily incorporate into your life from a place of empowerment and reminding you of your health and of your strength. I think that's the process.
Basically, from my perspective, one of the things that the world of conventional psychiatry and medicine in general is trying to do is we're medicating true anxiety or we're medicating false anxiety. Either way, I'm more interested when we're medicating true anxiety, because what happens then, I find, is people, like me, I was grieving. I got put on Effexor XR and Wellbutrin XL at 15. That changed the whole way in which I viewed the world. And then when I got off these drugs at 30 and went into horrible withdrawal, I had to deal with everything that was medicated to begin with. And it was very scary. I didn't have anyone guiding me. And I wish I had known that you existed at the time, because you're one of the really few outspoken psychiatrists who is helping people withdraw, who's very interested in this intersection between what happens during withdrawal and the emotional responses that come up from trauma, from childhood, et cetera. So I'd like to spend a little bit of time here, because I don't think we really have a lot of people who can speak to this the way you do, especially with the amount of folks you've been working with. One of the things that I find so fascinating is the level of anxiety that occurs during withdrawal. That can be far and away more intense than pre-medication or during medication. Can you talk a little bit about that, what you think is going on both physiologically and emotionally? And let's start there.
I was recently in Vienna, and I love to go to Europe and tell myself, like, all my problems would be solved if I were in Europe and there's not as much Roundup and whatever different hybridization process they're doing to the wheat. I don't know. But I remember feeling healthier, feeling great, and also looking around and saying to myself, there's no cure to the human condition. Like, even where there's less Roundup, people still have their struggles. And I think that that's part of the problem with conventional psychiatry is that we do pathologize normal responses to the human condition. We're going to lose people that we love. We're going to grieve. We're going to go through massive stressors. We're going to have senseless traumas in our lives. And so we're just culturally squeamish about that. And then we are, as a field, just not given the tools to hold space for that without being quick to say, I want to make your suffering go away. And I've been taught that if you're crying for more than this many months, that's now something we should pathologize. And so we need to medicate you. And so we just need to be with our grief. We need to be with our feelings. We need trauma-focused therapy for trauma. And to your point, when you medicate through a big emotional process, we have not made the energy of that emotion go away. There's conservation of mass with this. We can blunt our body's ability to emote it and to feel it and access it. But then what I find is that in that withdrawal process, there's a recapitulation of it, which is like a real fun salt on the wound of the withdrawal process, because that's already hard in its own right. And now you're hit with, oh, that divorce really did affect me, even though I didn't feel so affected at the time. Now I'm moving through those emotions or that loss. And so the energy never goes away. And I tend to believe that feel the feelings, the sooner the better. And so blunting them is unfortunate. There's a sidebar I want to take in a moment around the difference between psychedelics and antidepressants when it comes to feeling our feelings. We'll circle back to that. To your question, so withdrawal, there's like, you probably have many people come on and talk about how to support it, mechanistically. That's a conversation. But in terms of holding space for the feelings, I've learned a lot from Kelly Brogan on this. She kind of talks about it as an initiation, as a birthing process. The analogy that always feels true to me is childbirth. And I remember being in labor, and there's two things can be true about labor, which is this is so incredibly hard and you can do it. And I remember choosing between an obstetrician and a midwife. And one of the things that people said was good about having a midwife was that while you're moving through labor pains, they're going to be sitting in the corner knitting. And I was like, well, why is that a good thing? But what you actually don't want is a fear-based, reactive, intervention, trigger-happy approach to birth. That's actually not what's helpful. Of course, there's a time and a place for reacting. There's a time and a place for intervening. There can be emergencies. But for the most part, it's a painful process that's not wrong. And so you need to be able to move through it. And for the midwife to be like, I'll be over here knitting, you're doing great, mama, is actually the right balance. And I think with my patients moving through withdrawal, they're having intense anxiety, difficult sleep, irritability, akathisia, wanting to jump out of their skin, despair. And there was always a balance I'm trying to strike, which is I'm right here. I'm in the room with you, and I'm feeling this with you. And you've got this. And I'm not going to respond in a fear-based, reactive way. Because I think that's what our training tells us to do, is to say, oh no, this patient is having concerning thoughts. Like, I need to call 911. I need to recommend that they go to the emergency room. We all know how that story ends, right? That's not supportive of someone's healing process generally. Of course, there's a time and a place when someone has to be safe. But I think that for the most part, what I needed to do was, if someone was having a hard time, I just needed to be with them. We needed to talk. They needed to know they weren't alone in this feeling. But I didn't need to fix the problem, because that actually never fixed anything. And the intensity of withdrawal, an early patient, and I think this was probably my second year out of residency, taught me something really important about withdrawal. This was a guy who went on Prozac when he was going through a divorce. This is not someone who ever had quote unquote major depressive disorder. He never had suicidal thoughts. He wasn't someone who was depressed. He was going through a divorce and he was feeling overwhelmed and stressed in that context. He went on Prozac, then he started seeing me, and he's like, I'm good now. Everything is stabilized in my life. I want to get off of this medication. And I, was naive at the time. I was like, okay, probably recommended one of the tapers that I now, look at with horror. And he got off of the Prozac. And importantly, he started having suicidal thoughts. This is not someone who ever in his life had suicidal thoughts. He never had depression. He didn't go on this for depression. He went on this for life stressors and adjustment disorder. But in withdrawal, he became someone who was depressed, anxious, irritable, and suicidal. So that's where I started to realize we are taught that if someone goes off their medication and they become symptomatic, that is a relapse. This guy was not relapsing. There's no about this. This didn't go back to some state he was in before. This was a new state he was in. It was withdrawal. And the misattribution of withdrawal symptoms and calling them relapse is the thing I most have a bee in my bonnet about when it comes to the withdrawal world, because there's also a culture in medicine of a little bit of blamey dismissiveness toward patients. We say it's non-compliance. Now we kind of try to call it non-adherence to destigmatize the term, but it's basically like, you idiot, you went off your meds, and of course your disease came back because the meds were the correct treatment, and now you need that treatment again. So we call it relapse. We are wildly in denial of the fact that this is a real drug with a real withdrawal, and you're in a withdrawal state. Might someone later, quote unquote, relapse to quote unquote major depressive disorder? Sure, maybe. We can have that philosophical conversation, but we cannot evaluate that in the throes of acute withdrawal.
How many of your patients, or what percentage of your patients, experience new psychological discomfort during the withdrawal? And the reason why I asked that question is because there's a narrative in the withdrawal and tapering space right now that if you move slow enough, you can mitigate withdrawal symptoms entirely. I am not unconvinced through observation that there is not a purpose for these emotions and this discomfort when it comes up. And I struggle to find the line between when those feelings are useful, when that boomerang is effectively useful, and when it's an indication that we've moved too fast. And so you're in clinical practice, and I'm just wondering how you approach that.
So this question is like at the absolute outer bounds of my philosophical musings. I don't know. I think that when I'm faced with a patient, it's really individual. So sometimes somebody wants to mitigate withdrawal symptoms as much as possible. Doesn't matter how long the taper comes. They're sort of in fear of the withdrawal symptoms. Usually it's somebody who has had a previous experience with a taper that went too quickly and was traumatically difficult. And so they're like, it's basically like asking for the epidural. It's like, I don't care how long it takes. I just don't want to feel it. So that's usually something to even unpack on its own. It's like working through the trauma of the previous taper. And sometimes I have patients who are really game to roll with what comes up, and not to say we rush the taper or we tempt it or invite in big emotional outpourings, but it's always a balancing act of let's make this bearable, let's make this sustainable, because we don't want to go so quickly that we end up, one step forward, two steps back. But that when the big feelings come up, that it's fruitful. And I want to see that like really carefully and with sensitivity, because suffering is awful. And I don't necessarily think everything happens for a reason. I'm not really interested in the spiritual bypass view of that, but I think everything that happens is something that we can listen to and make meaning from. And so when my patients have a big emotional process with a taper, it's often very fruitful work for them, learning about themselves, learning about their wants, their desires, their needs, their fears. It's part of a self-actualization process. And so when it comes up, we roll with it. When it's unbearable, we do everything we can to mitigate it. And when it's not possible to fully mitigate it, we say, okay, there's something here to pay attention to.
Yeah, there's something also really interesting at the intersection between trauma and withdrawal that I find to be, again, fascinating in a way where this stuff's just so hard to research anyway, but it's just that the stories I hear, and I'm sure the stories you hear too, it's just like, there's not necessarily a direct line or impact between the thing that happened to you as a kid and your adult expression of it, right? Sometimes it's gradual. Sometimes we're just feeling kind of crappy and then we get given Prozac, and then 10 years later, we realize how crappy our childhood was, right? And we have to deal with it. But what I find is that withdrawal puts this weird little magnifying glass on it, and it can really throw people off. What could be happening there? And then how do you help patients go through and manage the trauma responses when they're in withdrawal?
I think that there is something so reminiscent about trauma with the withdrawal experience. And you can feel victimized by the prescriber who put you on a medication, by the prescriber who took you off too quickly, by an industry that doesn't support you or closed doors in your face when you tried to get support with the process. You can feel victimized by the pharmaceutical industry, and so on and so forth. And then there's this experience in your body where you feel powerless and scared, and that you don't have the ability to get yourself to safety. And I think that can recall trauma so much. And I think that when a trauma happens early in childhood, there's something that overwhelms the system. There's some stressor that overwhelmed the system. It wasn't able to be handled or processed appropriately at the time, whether that means you didn't have the language for it, you didn't have a way of keeping yourself safe, you didn't have a container, you didn't have support. It overwhelmed the system. And it's sort of like all this mess energetically got shoved into a closet in the brain, in the tissues, in the fascia, and it's just stuck there in a way that's making us symptomatic. But we didn't necessarily have a verbal, conscious, reflective way of making sense of that because it happened at a time before we were ready to do that. And so when you go through withdrawal in adulthood, it can be this opportunity in certain ways because your body revisits those old feelings. But now you're doing it from a place of an adult reflective brain. And there are ways we can work with that fruitfully. We can say, okay, you're feeling powerless, you're feeling victimized, you're feeling unsafe in your body. Can we secure you in some way? And I think that there's a parallel process that could be happening where in showing up for yourself, reparenting yourself, keeping yourself supported and safe in that, and getting the right supports around you, you're sort of doing something reparative to the past experience at the same time. I was going to say that's if you can move through the withdrawal experience with the right support in place. I think otherwise it can even be a damaging repetition of the earlier traumatic experience.
It's never occurred to me before that it's like it's time travel in a way, that whatever is going on in the biological body that sort of causes nervous system dysregulation, or we're all just hypothesizing what exactly is going on that is creating these feelings, but it really does. It's a straight line to, in my case, a childhood trauma of losing my dad so suddenly, and feeling all those feelings almost for the first time, right? I had never felt like the world and the floor had been pulled out from under me before. I didn't know what that felt like at 15. And then you're kind of in a state of shock anyway. And so who knows where those feelings were put or stored or whatever. But what I know is that when I went back into withdrawal, it was the first time that I think I had really felt that again on a physiological level. But I had no concept that somehow that these things could be connected. And they may not be like literally connected, but there's just almost like a recognition in yourself of the thing that is unwhole. And that actually explains a lot of my process in a way that's making me emotional, because I'm still trying to untangle all this stuff. I was actually with Angie Peacock yesterday, and we were talking about how working with other people who are in withdrawal helps remind us that what happened to us is real, because you really kind of don't feel like you don't know what you're making up and what actually happened.
It's interesting because the brain is the lens through which we see the world. And when the brain is what's going through the spin cycle, you can later look back and think, well, what was reality? What was true? But no, withdrawal is so real. I've even been sort of like provider gaslit by that once, where I was talking to a functional medicine practitioner, and I was like, well, what do you do to support withdrawal from psych meds? And she told me, well, my patients don't really experience withdrawal when I get them off psych meds. And I remember thinking, am I the problem? Am I a bad doctor? And like, am I leading the witness in helping? And then I came to realize, no, that like we don't do a good job asking the right questions to elicit that information from patients. Withdrawal is so very real. And I do think we need to turn to others because the industry itself gaslights all of us about that it's real. But I think that the way withdrawal pulls the neurochemical rug out from underneath us, from the brain, I think you're exactly right that it takes the body right back to that trauma. And I think the few people who don't have a hard time with withdrawal are sometimes the people who don't have trauma. And I think in certain ways, having a history of trauma can enhance the withdrawal experience because there's a memory in the body of, I know this feeling and this was scary. My survival was at risk. Someone else's survival was at risk. The body says, like, I know this and this is not okay. And, I'll just say till the end of my days, like, we just need more space for grief. And like, I remember after my mom passed away and I was in Brazil working with ayahuasca, and one of those ceremonies I experienced as a funeral for my mom. And I thought to myself, like, that's how you do a funeral. Like, to witness the person that the community has lost, to cry, like to cry so much more than I even knew I had the ability to cry, and to just feel it so big. And there's so much more honoring and witnessing and space for emotions. And here we are in the United States in 2024, and we just do not have the systems or rituals in place to appropriately grieve. We don't have the time off from work. We don't have the, we're in an emotion phobic culture. We are surrounded by people where the minute we start to cry, they get uncomfortable. We feel like a burden. We start to apologize. We try to suck it back in the way a person would suck in a sneeze. And we think if I just like pinch the sneeze and make a little chew, then that was successful. And I think we need big, messy, ugly, full, complete cries. And we need to do that in the presence of people that can hold that space for us. And we need the ability in our lives to drop to our knees and have primal waves of grief wash over us, even at inconvenient times. And so we just need more grief. And grief to me is not such a negative thing. I've now been through 2 big losses. Arguably, if you sort of throw pregnancy loss into there, add 3 more onto the pile. And it's not something that I think of when I'm really grieving. I don't think of that as a negative thing. I am unhappy about the fact that I've lost this person that I love. And there's a lot of complexity to everything I'm working through, looking back at my role in the relationship, what I wish I had done differently, so on and so forth. But also, grief is this exquisite feeling of, it's actually in certain ways it's a cover of the song Love. It's it's kind of a minor melody, but it's the same song. And it was my sister who really had this insight for me first when I was pregnant, when I lost my mom. And I remember having the passing thought of like, is this not ideal that I am deeply grieving and I'm pregnant? And it isn't ideal, to be honest, right? Like epigenetically, there's something to that, but that's what my daughter contracted in to do this lifetime. But what my sister said was she said the placenta filters the grief, and the only thing that gets through to the baby is love. And so I really carried that image every time I had huge primary wailing cries throughout that pregnancy, was that this is just bathing my baby in love. And I think we just need more space for that, and even a reframe on grief as not being so negative, not being a burden on the people around us, that we all have a debt of unprocessed grief. And if we grieve around each other, we even give each other permission to move through that.
And I think too, grief doesn't necessarily have to be because of the death of a person. Like I've been through plenty of that, and also have had grief that is almost as strong. Maybe not, I'm not going to say as strong, but very close in the same ballpark, over the loss of a relationship that didn't die, right? Like the loss of a friend or jobs or a home. And when we layer that on top of it, and people can have so much attachment to the things that they love or they care about or they put meaning in. And when that is taken away, I think so often what people describe to me as what they're experiencing is just pure grief. But because someone didn't die, they think they're mentally ill.
And unrealized dreams and pregnancy loss and, not having the children that you want, having the children that you asked for. Like it's all, we just need to be working with all of the losses, big, small, and none of them are invalid. And there's certainly no oppression Olympics when it comes to grief. Like whatever's hitting you on this note, like sing it. And I think that, the fact that we pathologize this, like again, back to Vienna, there's just no cure for the human condition. We're going to experience losses in our life, and there's no more valid or less valid. We just need to give ourselves permission to feel it, to be with it.
One of my absolute favorite quotes of all time is from Joanna Cacciatore, the researcher on grief, who said to me once, "Grief waits for you until you're ready to do the work." And that to me, I think, has just been possibly the most true thing I've ever heard, because there's no cure for the human condition. Whatever the thing is just waiting for you. You can medicate it for as long as you want, but it's going to come up one way or another. I'm so glad you're talking about this. And this is what a lot of the new book is about, right?
Yeah, it really starts with my experience with grief. But then, I think that for me, it engenders a whole exploration of spirituality. And that's an awkward thing to write about and talk about, especially like as a physician. It's not, we're kind of squeamish about that topic. But yeah, I think that can we listen for what feels true and resonant for us in these moments? Like I really kind of lost, people like we have the REM song, Losing My Religion. I lost my atheism when I lost my mom. I lost the ability to perceive this world as senseless and random and purely material. And I'm really happy about that. And so it's an exploration of that, not to say that there's one path for all of us. There's so many different paths, and it's uniquely ours each and every time. But at least maybe a swing on the pendulum back toward giving ourselves permission to seek in that way.
I feel like there's actually been quite an interesting shift in how we're talking about all of this and whatnot in the past 2 years. So just to close, I wonder, has there anything you've changed your mind about in the past 2 years since you've written the book?
It's the best question. And what came into my mind, here's what's most honest and not necessarily the right answer. There are ways that I would make industrial strength caveats now that I didn't then, like not anticipating all of the pushback that you get with these really charged, nuanced, uncomfortable conversations where people will misunderstand. And like, the spirit of how I approach mental health always is like, there's no judgment, there's no shame, there's no blame. Let's walk through this jungle together and find a relief to suffering, or at least a way of being with it in a fruitful way. One friend of mine she really got into my head when she talked about my approach to nutrition with mental health, which I'll die on that hill all day. Nutrition matters. She was like, it's giving diet culture. I think that like I would go deeper into the nuanced reflection on that, because we exist in this tension between toxic diet culture and a form of, not all, but a part of body positivity that, as Will Cole put really well, is an overcorrection. And so, yeah, I think that I would even just explore that more, because we just need a way of nourishing ourselves without fear and fragility and drama, and without shame about our different bodies. And we need to find a happy medium in there. I will close by saying, Brooke, like just so much gratitude to you for the role you play in this incredibly important ecosystem, and this aspect, this niche of medication withdrawal, and just having the nuanced conversations about the pharmaceutical industry. It's still, to this day, like we still do not have anywhere near enough of a conversation about it. So thank you for doing the work that you do. And I'm just grateful to get to come on here and share my musings on the topic.
Likewise, I hope your soapbox grows and grows and grows, because you've been such an example to me, and I've learned so much from you. And it's just the more clinicians that start to understand this, the better. So thank you. And I can't wait for the next book.
Brooke, thank you.
Thank you for listening to the Mad in America podcast. For more news, views, and updates, visit madinamerica.com.